My name is Dr. Robin Dore, and I am a clinical professor of medicine at the David Geffen School of Medicine at UCLA in Los Angeles, California. Today we are going to be talking about quality measures in rheumatology. The need to practice cost-effective medicine and to provide it in the safest way was the driving force behind quality improvement programs in medicine. Quality healthcare is the priority for Health and Human Services and the Center for Medicare and Medicaid Services, which is called CMS. CMS uses quality measures in its various quality initiatives that include quality improvement, pay for reporting, and public reporting. Quality measures are tools that help us measure or quantify healthcare processes, outcomes, patient perceptions, and organizational structure and/or systems. Examples include clinical outcomes, clinical processes, patient safety, care coordination, and adherence to clinical guidelines. They are associated with the ability to provide high-quality health care. The quality goals for health care include effective, safe, efficient, patient-centered, equitable, and timely care. All of the different specialty associations were asked by CMS to submit suggested quality measures to be included. PQRS, which is the Physician Quality Reporting System, is a quality reporting system that previously rewarded eligible professionals for satisfactory reporting data on quality measures for services to Medicare Part B beneficiaries. In 2015, eligible professionals who successfully reported PQRS measures did not receive an incentive payment but avoided a 2% negative payment adjustment. Data on quality measures are collected and reported in several ways, including claims, assessment instruments, and registries. CMS requires users to report at least 9 measures covering at least 3 NQS domains and report each measure for at least 50% of the eligible professionals' applicable patients seen during the reporting period to which the measure applies. We also must include at least 2 outcome measures. NQS domains include patient safety, person and caregiver-centered experience outcomes, communication and care coordination, effective clinical care, community and population health, and finally, efficiency and cost reduction. The American College of Rheumatology offers the RISE registry to its members. It is a CMS certified registry and meets PQRS requirements. The RISE registry is a QCDR registry, so therefore it is different from a traditional registry in that it is able to submit non-PQRS measures, so there's more flexibility to report on measures that are clinically meaningful to rheumatologists. So how does it work? First, a member signs a contract to allow data extraction from their EHR. Then the registry collects data to make certain that the member has reported the necessary quality measures. A registry representative meets monthly with the member online to review progress towards the goal of reporting the required quality measures. A note of caution, however, is that while rheumatologists who use RISE will satisfy the registry reporting requirement of meaningful use, they will still be required to meet other meaningful use objectives through the CMS registry and attestation. RISE users will report on the RA group of 8 measures. The 2015 PQRS RA measure group is composed of 6 RA-specific measures and 2 non-RA specific measures. The RISE registry also includes 2 additional non-PQRS RA measures. PQRS RA measure number 108 is concerning disease-modifying anti-rheumatic drug therapy, or DMARD therapy, for the percentage of patients aged 18 years of age and older who are diagnosed with rheumatoid arthritis and who were prescribed, dispensed, or administered at least 1 ambulatory prescription for a DMARD. So this is really to make certain that for our RA patients that we are providing most of them with DMARD therapy because this is considered the standard of care. Quality measure number 128 is one of the non-RA specific measures, and it's preventive care and screening of BMI, the percentage of patients aged 18 years of age and older with BMI documented during the current encounter or during the previous 6 months, and reporting a plan to try to improve this patient's BMI. As you're aware, we know that patients with rheumatoid arthritis who have an elevated BMI, it's associated with increased adverse events, and sometimes higher doses of the medications are needed. So this is important that we try to keep our patients' BMI in the normal range. PQRS measure number 131 is another of the non-RA specific measures, and it is for pain assessment and follow-up. It's the percentage of visits for patients aged 18 years and older with documentation of a pain assessment using a standardized tool on each visit and documentation of a follow-up plan when pain is present. So as you know, there's an emphasis now on adequate control of pain, and so this measure makes certain that we not only address the tender and swollen joints of our patient, but also that we adequately control their pain. Now back to the RA-specific measures, number 176. This is with regards to tuberculosis screening and the percentage of patients aged 18 years of age and older with a diagnosis of RA who have documentation of a TB screening performed and results interpreted within 6 months prior to receiving a first course of therapy using biologic disease-modifying anti-rheumatic drugs. So the purpose of this measure is to make certain that we provide adequate tuberculosis screening for our patients before we start them on biologic therapy. Measure number 177 is back to our RA-specific measures, and this is periodic assessment of disease activity, and this is the percentage of patients aged 18 years of age and older with a diagnosis of RA who have an assessment and classification of disease activity within 12 months. And this is really what the ACR rheumatoid arthritis guidelines are emphasizing, that we need to use a treat-to-target approach and measure the patient's disease activity. Measure number 178 is the functional status assessment. This is the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis for whom a functional status assessment was performed at least once within the prior 12 months. PQRS measure number 179 is assessment and classification of disease prognosis. This is the percentage of patients aged 18 years and older with a diagnosis of RA who have an assessment and classification of disease prognosis at least once within 12 months. And this is a way that in the future our quality of care will be measured, because those who are assessing our data to determine if we are providing quality care want to make certain that our RA patients have a good disease prognosis rather than a bad disease prognosis, so that we can adjust therapy appropriately. Measure number 180 is glucocorticoid management, and it's the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis who have been assessed for glucocorticoid use, and for those on prolonged doses of prednisone greater than or equal to 10 milligrams daily or its equivalent, with improvement or no change in disease activity, documentation of glucocorticoid management plan within 12 months. So again, a good quality measure showing us that we need to document the dose of glucocorticoids that they're on, and then our plan to try to taper them off the prednisone. Now we leave the PQRS RA measures and go to an ACR RA measure, intervention if RA worse. If a patient has rheumatoid arthritis and is being treated with a DMARD, and there is evidence of increased disease activity, or there is evidence of progression of RA bony damage over a 6-month period of time, then one of the following should be done. Change DMARD dose or route of administration, change DMARD, add an additional DMARD, start or increase dose of glucocorticoids, or provide local glucocorticoid injections unless the patient refuses or all of the above are contraindicated. So at times I have a patient who I feel that they could be doing better, but they feel that they're doing okay, and they're afraid to change to a different therapy. So that would be allowed based on this measure, but we need to document that the patient refuses to change their DMARD, and therefore we are continuing on that drug even though we feel that their disease could be better controlled. And finally, to the last non-PQRS ACR measure. This is looking at disease activity measurement for patients with rheumatoid arthritis. And this is the percentage of patients aged 18 years and older with a diagnosis of RA whose disease activity is assessed using a standard measurement tool at 50% or more encounters for rheumatoid arthritis by the same clinician during the measurement period. And again, the ACR does not state what metric we need to use. In the office, I use the CDI. Some people use Rapid3. Some people use an SDI. So again, the purpose of this measure is that the agencies who are measuring the quality of care we provide can see that the majority of our patients with rheumatoid arthritis have low or moderate disease activity. And if they don't, then we document a plan to change medications to get them into low or moderate disease activity and hopefully even remission. So what we've reviewed so far is that there are 8 measures, 6 PQRS measures specific for rheumatoid arthritis, 2 non-specific RA measures, and 2 ACR measures. Also, I mentioned at the beginning that we needed to cover 2 NQS domains, which we have with these, and also 2 outcome measures, and both PQRS number 177 and 178 are outcome measures. So what is the future of quality measures? CMS will continue to develop new measures that address detection and prevention of medication-related adverse events. Many new measures will focus on medication adherence. Personalization of healthcare will expand. This has already begun. For example, one of the measures addresses whether we discuss with elderly patients when we initiate medications that are considered dangerous in the elderly, medications that are considered less dangerous, and do we have a documented plan for follow-up to monitor for adverse events. A more sophisticated feedback loop between measures and outcomes will be developed so that the system can rapidly evolve toward measures that matter to patients and providers rather than those that are the easiest to measure. And I put this in quotation marks because these are not easy to measure, but it's very important so that we can show that we are providing quality care to our patients. The Institute of Medicine calls this a learning healthcare system. This learning system depends on the collection and analysis of clinical data from our EHRs. Rheumatologists need to make certain that data are available and easily extracted from the electronic healthcare record by the RISE registry, your university, ACO, MCO, or another organization that is CMS accredited. In the future, the rheumatologist who provides the best healthcare will be paid. This will be assessed by outcomes measures such as remission and low disease activity in response to therapy. So I hope this review of quality measures in rheumatoid arthritis will be helpful to you, not only meeting the goals that we need in documenting our visits, but in providing quality care to the patients, as our goal is certainly to provide the best care possible for our rheumatoid arthritis patients. Thank you very much.